Thank you for the introduction and invitation. This is the pathological topic, the only one for today, so it's the treat of the day. I'm going to talk about the T-cell lymphoma update in 2016 revision of WHO. As we know, the previous Blue Book was published in 2008, and it's been 8 years since then. And there were increase in the knowledge of molecular genetics, biology, and clinical behavior of many neoplasms. This edition is actually a revision of the 4th edition. It's not a 5th edition for the WHO. And I'm going to only talk about the important things in T-cell lymphomas or neoplasm. This is the previous 2008 classification of T-cell lymphoma and the NK cell lymphomas. And there have been many changes, including the one highlighted in red. I'm going to talk about the major things. I'm not going to go in details about what's been added in some informations like in the gamma delta T-cell lymphoma or the peripheral T-cell lymphoma. So what's new in the 2016? First, we have the T-cell large granular lymphocyte leukemia. It's a very rare leukemia, has a clonal proliferation of cytotoxic T-cells. And the most important thing in this chapter that the STAT3 and STAT5B mutation are associated with an aggressive disease. As we know, we are more developing genetic profiling now that can help in target therapy. So it's very important to know which has a better or worse prognosis for the patient. The systemic EBV positive T-cell lymphoproliferative disorder of childhood is a part of EBV positive T and NK cell lymphoproliferative disorder of childhood. They changed the name from lymphoproliferative disorder into lymphoma because the patient usually die within the first 2 weeks after the diagnosis. It has a very fulminant clinical course, and it should be distinguished from chronic active EBV infection, which has a better prognosis. The hydrovacciniform-like lymphoma, it's also part of EBV positive T-cell, NK cell disorders, and they have been changed from lymphoma into lymphoproliferative disorders. Patients usually have vesicles or recurrent ulcer in the skin, and usually they have a very long or chronic clinical course. And it's variable from patient to another patient. To develop a systemic disorder, it may take a long time. That's why they call it a lymphoproliferative disorder instead of lymphoma. This is a picture showing a child with these vesicles, and there is down, we have skin infiltrating by the cytotoxic T cells. Next are the enteropathy-associated T-cell lymphomas. Previously, as we know, in 2008, we have type 1 ETL and type 2 ETL. Type 1, as we know, associated with celiac disease. In the 2016, it's called enteropathy-associated T-cell lymphoma ETL without numbering. And type 2, it's a monomorphic epitheliotropic intestinal T-cell lymphoma METL. So, regarding ETL, it's, as I said, it's associated with celiac disease, and it's like the CD4 and CD8 positivity, also CD56. Usually, the tumor cells infiltrate the intestine, making ulceration and destruction of the gland. As we can see in the right side in this picture. METL, which is known as ETL2, has no association with celiac disease, and it's positive for CD8 and CD56. Both enteropathy lymphomas, they have very bad prognosis and poor outcome. And this is another picture. It has the same thing. The lymphocyte will attack the mucosa of the intestine. And these are the immuno CD3 positive, CD4 is negative, CD8 and CD56 are positive. The ALK negative anaplastic large cell lymphoma, in 2008 it was a provisional entity. Now it's a definite entity and single entity. As we know, a lacking of rearrangement of ALK give the patient poor prognosis. Because of the genetic profiling, we found out that these cases may have rearrangement of DUS-P22 with IRF4 in chromosome 6, P25, or rearrangement of TP63. In this diagram, it shows that here, the blue one, the patient with DUS-P22, actually they have similar prognosis to patient having ALK rearrangement. So it's good news for the patient to have DUS-P22 rearrangement. Unlike TP63, patient with TP63, that means most probably they're gonna have very poor prognosis. The primary cutaneous CD4 positive small/medium T-cell lymphoma was a provisional entity in 2008. Now it's a distinct entity, but they found out that it's a localized disease, usually a nodule in the head and neck area. It has a limited risk, does not proceed to systemic disease, and it has a good response to treatment. So they call it primary cutaneous CD4 positive small to medium T-cell lymphoproliferative disorder. This is a picture showing a nodule in the head and neck area. Next is the provisional entities. The new entities been added in 2016. We have the indolent T-cell lymphoproliferative disorder of the GI tract. Usually patients present with the polyps in the GI tract, especially in the small intestine or colon. It's a wax and wane. Patient will have a chronic history. There is no systemic disease. In histology, you cannot see the destruction of the glands, only infiltration of clonal T cells. It is stained for most of the T cell markers. It does not respond to chemotherapy usually. The primary cutaneous acral CD8 positive T-cell lymphoma, another new entity. It's very rare. First represent in the ear area, and it composed of clonal atypical T cells. It has a very good prognosis because it responds very well to treatment. Breast implants associated anaplastic large cell lymphoma. Now it's a provisional entity, and it should be distinguished from the ALK negative, ALCL. Patients usually have a good prognosis because they present with a seroma that having tumor cells around the capsule. The treatment is removing of this capsule with the implants. Patients have very excellent outcome. Some patients may present with the breast mass and involvement of lymph node. Usually these patients have lower outcome than the classical one. The last one is the nodal peripheral T-cell lymphoma. In 2018, we have the peripheral T-cell lymphoma NOS with its variant, the T-zone, the lymphoepithelioid, and follicular variant. And the other one is the angioimmunoplastic T-cell lymphoma, which is arising from the T follicular helper cells of T cells. In 2016, they figure out the follicular variant of PTCL NOS is actually part of the T follicular helper cells. And they find out another entity under the umbrella of the T follicular helper cells, which is the Nodal PTCL with T follicular helper phenotype. So now we have under this umbrella: angioimmunoplastic T-cell lymphoma, follicular T-cell lymphoma, and nodal PTCL with TFH. The nodal T-cell lymphomas that under the umbrella of the T follicular helper cells, they share almost the same morphology. They have immunophenotype of T helper cells, which is PD1, CD10, BCL6, ICOS, and CXCL13. The gene expression also is almost the same, and they are overlapping together. So these are the new provisional entities being added. Some of angioimmunoplastic T-cell lymphoma can show the IDH2, DNMT3A, and TET2. Also, PTCL of T follicular helper phenotype also show TET2 in some of the cases, around 60%. And angioimmunoplastic T-cell lymphoma, 60% can show mutation of RHOA. Briefly, angioimmunoplastic T-cell lymphoma is the most common T-cell lymphoma, usually affects elder people, and it's systemic disease. On histology, we see a polymorphous infiltrate, proliferation of the high endothelial venules, and follicular dendritic meshworks that been expanded. This is very characteristic of this type of tumor. Also the EBV positive immunoblast cells. And this is a picture showing the high endothelial venules surrounded by the tumor cells. And here we can see some big cells, which most probably are immunoblast and positive for EBV. Regarding the follicular T-cell lymphoma, it's nodal-based, unlike the angioimmunoplastic, has a follicular growth pattern. It lacks the proliferation of high endothelial venules or the meshworks of dendritic cells. But 50% of cases show EBV positive cells immunoblast, and it shares the same immunophenotype and the genetic profiling of angioimmunoplastic. The nodal PTCL with TFH phenotype show diffuse growth pattern. Usually it's not a polymorphic, more of monomorphic. Also lack the proliferation of endothelial cells, lack follicular dendritic cells meshworks, and no EBV positive cells. But the immuno, it's of T follicular helper cells, and the genetic phenotype also same as angioimmunoplastic T-cell lymphoma. These two entities are provisional. I think they're gonna, next time they're gonna have more details, because it's so difficult to differentiate between these two and the overlapping with angioimmunoplastic lymphoma. We're gonna have more insight, and I think we're gonna have a lot of retrospective study regarding these cases which been diagnosed as PTLC, NOS, or angioimmunoplastic. These are my references for today. And at the end, many questions remain. New insight will lead to more accurate diagnosis and improve therapy. Thank you.